virtual meeting, and I have no disclosures. My task today is to talk about the pitfalls in the assessment of valvular disease. My plan is to focus on some of the common ones that we encounter on a regular basis. Echo is essential in the assessment of valvular heart disease. Not only can we learn the type of valvular dysfunction, we also gain insight into the etiology, mechanism, and severity of the dysfunction. Furthermore, a good understanding of intracardiac hemodynamics, such as filling pressures and pulmonary artery pressures, can frequently be obtained. The severity and clinical significance of a valvular dysfunction should not be based on a single measure. Indeed, the strength for echo is that multiple anatomic and functional aspects can be assessed in the same setting. But we do need to be aware of the limitations and variabilities inherent in any of these measures. We should include both qualitative and quantitative variables and bear in mind that our assessment should be interpreted in the context of the patient's hemodynamic during the study. Let's look at the case of this 69-year-old woman who had a myocardial infarction in 2018. She went on to have stent to her left circumflex artery, but ended up with a left ejection fraction of 37%. She has become progressively short of breath for the last 2 days prior to presentation. Her blood pressure and heart rate are shown on this slide. The poststernal images confirm left ventricular dysfunction. The posterior wall is thin out and akinetic. There was restriction of the posterior mitral leaflet. Moderate mitral regurgitation was present, which was directed anteriorly. These images show the right ventricular inflow view and the view of the pulmonary artery. At least moderate tricuspid regurgitation is seen, and the spectral Doppler showed that the peak tricuspid valve velocity was about 3 meters per second. Mild pulmonary regurgitation was also present, with early diastolic velocity about 2.8 meters per second and end diastolic velocity 2 meters per second. What do you think her pulmonary artery systolic pressure would be, assuming a right atrial pressure of 8 millimeter mercury? Was it 36, 44, 57, or 65? This was a study that I was involved in during my fellowship long time ago. We performed Doppler study to assess the tricuspid regurgitation velocity in the cath lab and compare the gradient from RV to RA gradient by Doppler with cath measurements. We showed that there was very tight correlation between these two measurements with an R value of 0.96. But there are many other studies that did not show such a tight correlation. And there are several reasons for that. Firstly, in many of the studies, the Doppler assessment and cath assessment were not done simultaneously as it was done in our study. And we know that the pulmonary artery pressure can vary quite considerably from hour to hour. The more important reason for the poor correlation is using suboptimal tricuspid regurgitation signals. This is one example. You can see that the envelopes of the tricuspid regurgitation signal are not well displayed, and there is considerably difference of the peak velocity from beat to beat. And yet, very often, the pulmonary artery systolic pressure was based on such suboptimal signals. Let's return to our patient. Although the tricuspid regurgitation envelope is quite complete, we note that the early pulmonic regurgitation velocity was 2.8 meters per second, which gave a mean PA pressure of 39 mmHg, which would be not consistent with a PASP of 44 mmHg. So what would be the reason for this discordance? We should not interrogate tricuspid regurgitation just from one window. When we examined the tricuspid regurgitation from other windows, we found that the velocity was actually considerably higher. You can see that the velocity is about 3.2 meters per second from the short axis view and 3.8 meters per second from the apical window, giving a PASP of 65 mmHg, highlighting the importance of good alignment of the velocity jet with the Doppler beam. The importance of interrogating multiple windows to ensure good alignment of the velocity jet with the Doppler beam is well known, particularly in the assessment of aortic stenosis. In this example, there's a good spectral envelope of aortic stenosis from the apex, and most of us would probably be happy to accept that as the aortic velocity. But from the right sternal border, you can see that the peak velocity was clearly much higher, again emphasizing the importance of using multiple windows. Our case shows the importance of getting robust primary data from 2D and Doppler. The primary data are the basic measurements that are then used to calculate other indices. For 2D, we are talking about LV dimensions and wall thicknesses, from which we can derive LV volume, LV mass, and ejection fraction. For Doppler, we are talking about the peak velocity and the duration of the velocity signal. To assess valvular dysfunction, multiple windows should be used, and good Doppler alignment with the velocity jet is essential. In order to achieve that, non-imaging probes should be readily used, especially in patients with aortic stenosis. The next case was a 79-year-old woman with hypertension and hyperlipidemia. She had no diabetes or stroke. She had a bypass surgery in 2012, and unfortunately, she had developed recurrent angina. A recent coronary angiogram showed that the grafts were patent, but she had severe native disease. Her blood pressure during the echo study was shown here. She was clearly hypertensive with a blood pressure of 202/66 during the echo study. The peristernal images showed normal left ventricular size and function. No apparent regional wall motion similarities were identified. The aortic valve showed sclerotic changes. There was also mitral annular calcification. The apical images confirmed normal left ventricle size and function. There was mild mitral regurgitation and tricuspid regurgitation. No aortic regurgitation was detected. Doppler interrogation included pulse wave interrogation of the left ventricular tract shown on your top left, CW interrogation of the transaortic velocity shown on your top right, CW interrogation from the suprasternal window in your lower left, and CW interrogation of mitral valve on your lower right. Doppler interrogation from the right sternal border did not show adequate signals. The highest systolic velocity was obtained from the suprasternal border and was about 4 meters per second. The hemodynamics are summarized on this slide. The aortic valve area and intextile area were based on a left ventricular tract dimension of 2 centimeters. So the question is what to do next. Should we repeat the echocardiogram after the blood pressure is controlled? Should we consider doing a dobutamine stress echo? Should we proceed with angioplasty, which is feasible? Should we proceed with replacement of the aortic valve percutaneously? Or should we proceed with surgical aortic valve placement with repeat bypass concomitantly? The effect of blood pressure on measurements of aortic stenosis has been investigated by our group. We show that elevation in blood pressure may result in a decrease in aortic valve area, meaning more severe aortic stenosis, largely in patients with a decrease in transvalvular flow. Thus, repeating the echo after the blood pressure is controlled is unlikely to be very useful in this case of severe aortic stenosis. The use of dobutamine stress echo is mainly to differentiate true from pseudo-severe AS in patients with low transvalvular gradient and low EF. This test is clearly not relevant in our patient with normal EF and high gradient. So what should we do then? I think our decision was to proceed with angioplasty and at the same time try to get better control of her blood pressure. Let's go over the reason why this decision is appropriate. Let's return to her echo images. You can see that although the aortic valve is sclerotic, it opens quite well. It would be unusual for this to create significant severe aortic stenosis. And if we examine the spectral Doppler again, and we can see that from the apical window, the transvalvular gradient is actually quite low, with no significant stenosis, and this is in agreement with the 2D pictures. So the unusual aspect is the high velocity obtained from the suprasternal window. Now, what could account for that? The high velocity was due to stenosis of one of the arch vessels, which was later found to be a tightly stenotic left common carotid artery. And you can see the turbulent flow in the arch vessel on the left-hand side of your screen. This case underscored the important connection between structure and function. When the valve appears to open well, it would be inappropriate to believe that it is stenotic based on the Doppler signal by itself. A more common scenario actually is a highly sclerotic immobile aortic valve and low transvalvular velocity. In that case, it also would be inappropriate to conclude that this represents mild aortic stenosis without further testing. The other important point illustrated by this case is that CW Doppler is not range specific, meaning that it can pick up abnormal velocity along the whole path of the Doppler beam. This point needs to be kept in mind when you encounter unusual velocity signals using CW Doppler. This phenomenon can also be encountered when you are using pulse Doppler, although is a less common phenomenon. The common pitfalls in the assessment of valvular disease are summarized in my last slide. We need to be particularly obsessive when reviewing suboptimal studies. Do not accept measurements based on incomplete velocity envelopes. Multiple windows need to be used, particularly in the setting of eccentric flow jets. Non-imaging probes should be readily used in patients with aortic stenosis. There is a close connection between structure and function. When there is a discordance between structure and function, we should look at the reliability of the measurements, including proper positioning of the sample volume and unusual flow velocities along the entire CW Doppler beam. There are limitations of hemodynamic assumptions under specific conditions, but time does not allow me to cover them.
Good afternoon. My name is David Buick, a cardiologist in the New Brunswick Heart Center in St. John, New Brunswick, and I'm talking today on the pitfalls in stress echocardiography. Conflicts to declare include being on an ad board for AXIA and Amgen. The objectives of this talk are to review the technical and operator issues, to review false positive and false negative stress echo studies, pitfalls with stress echo, and to follow the last part of the talk with case studies. By far, the number one issue with stress echocardiography are suboptimal images, particularly involving the posterior and lateral segments. The next issue is that stress echocardiography is a dynamic study, so you need to have the eyeball effect, which means it is dependent on operator expertise. Volume is necessary. You have to do a fair number of stress echoes to become competent in reading stress echocardiography. I'd like to highlight it is important for the physician to be present. Here's a stress echo of a lady with exertional symptoms consistent with angina, and the initial images acquired showed normal left ventricular function both at rest and peak exercise. However, I was there acquiring the loops, and we did a few subloops. Here is one loop showing normal left ventricular function. Here is another loop highlighting how one could miss this apical septal wall motion abnormality if you accepted the first loop. And the second loop was acquired by going slightly superiorly towards the LV outflow tract. As we mentioned, this is a dynamic study. One can have, however, false positive studies, particularly in underlying cardiomyopathies, left bundle branch block, or severe hypertension. A false negative study can occur in left ventricular hypertrophy, an inability to achieve a target heart rate, or single vessel coronary artery disease, particularly the circumflex. A stress echo may have sensitivity of 80-85% with a proximal LED lesion, but perhaps maybe 70% sensitivity for detecting ischemia with a circumflex lesion. One may consider nuclear imaging if one has severe hypertension, frequent ventricular ectopy, which would make it a challenge trying to digitally acquire the images, a loop, patients with severe or advanced chronic obstructive pulmonary disease, or significant obesity. Now, on a personal perspective, one requires dedicated training after comprehensive echo fellowship has been mastered. These are technically demanding, and it's better to have 100 exams reviewed with an expert than to do 500 on your own. The physician must be present during a stress echo, as highlighted in the previous slide, case example, and your lab and physician, along with the sonographer, need a volume of 40 to 50 exams per month. When one looks at clinical issues with stress echocardiography, I thought I'd highlight the bundle branch block, significant symptoms but a normal stress echo, an impressive ST depression but a normal stress echo. Pitfall number 1, a bundle branch block. I'd like to highlight this through a case example. This is a 77-year-old pilot who's applying for his license annually. He had no cardiac risk factors. He's never been to the hospital, on no medications, and his exam and blood pressure were normal. Federal transport mandated that he needed a stress test before clearing his license. Now, a stress test will be challenging with this type of ECG. As you can see, at rest, there's inferior T-wave inversions with a right bundle branch block, and at peak exercise, he has further ST depression inferiorly. So this study was interpreted as showing ischemia by ST criteria, even though he was asymptomatic. Federal Transport said they would give him his license if he had a negative stress echo, and hence I got involved. Here's his stress echo, which shows normal resting LV function, and at peak exercise, increased contractility of all segments with no wall motion abnormalities. When we look at the apical four-chamber view, again, normal contractility of all segments. Now, he is a 77-year-old pilot with an abnormal ECG, and stress echocardiography is highly useful for detecting ischemia, but because he's a pilot, I thought it wise to obtain a CT angiogram to non-invasively assess his coronary anatomy. And this did show some calcium in the proximal LED, but no obstructive coronary artery disease, and he was given his license. The next challenge in stress echo I thought I'd like to highlight is the left bundle branch block. This can be difficult with stress echocardiography. His stress echo showed normal resting LV function, but one sees a drop in his ejection fraction with several wall motion abnormalities. His septum is thinned and hypokinetic. Hallmark of ischemia is lack of endocardial thickening. One can see his inferior wall, his basal to mid-inferior segment are akinetic. In his apical three-chamber view, one can see his anteroseptum is hypokinetic, and there's some hypokinesis of the posterior wall. In the long axis and short axis, again, one sees the anteroseptum is hypokinetic, and we can cross-reference that in the short axis view. So the anteroseptum that you see in the long axis can be referenced in between the 10 and 2 o'clock position in the short axis view, and in addition, his inferior wall is hypokinetic. This prompted a cardiac catheterization, which confirmed and occluded LAD and RCA, and he was treated medically. Now I'd like to highlight an example with a left bundle branch in the elderly. This is an 81-year-old lady who was short of breath. She went 2 minutes and 16 seconds on a modified Bruce protocol with her heart rate at peak exercise at 97, and she developed a flat or hypotensive blood pressure response. Her ST shift was non-diagnostic, given her LBBB. One can see again clear abnormality of the left ventricle with a dilated cavity size, dyskinesis of the septum, and clearly several wall motion abnormalities. She had a cardiac cath which showed 3-vessel disease, and she had a multi-vessel PCI. The last example I'd like to show with an underlying LBBB is a 70-year-old lady who liked jogging, but found when she was going up a hill, she'd be very breathless. She had concerns because of her family history with her father dying of a myocardial infarction, and she was referred for a stress echo. She went 6 minutes on a Bruce protocol, achieved a maximum heart rate of 156, with the endpoint being dyspnea. One again sees this abnormal peak echo. There's LV deformation, reduced ejection fraction, the cavity size looks bigger, and there's multiple wall motion abnormalities. The normal triangular appearance of the ventricle is distorted to this oval globular shape. One should have a triangular shape both at rest and peak exercise with healthy non-ischemic myocardium. You can see the lateral wall is dyskinetic, the anterior wall is severely hypokinetic. The apical three-chamber view again highlights triangular shape, normal resting LV function, peak echo, oval, or deformed left ventricle peak exercise. An eyeball clue to a reduced ejection fraction with significant underlying coronary disease. The short axis view is not entirely helpful great portion of the time, but can be. Some of the reason is a small hypertrophy left ventricle can be difficult to determine if there's wall motion abnormalities. One can see the anteroseptum shows lack of endocardial thickening, but if you look at that same spot between 11 o'clock and 1 o'clock, there's clear akinesis or hypokinesis in the anteroseptum. So if you look carefully, you can find wall motion abnormalities, even in the face of LVH. So this study showed a dilated left ventricle with multiple wall motion abnormalities. She went on to have a cardiac catheterization, and then this demonstrated and confirmed a proximal LAD lesion, which was stented. The teaching points from these previous case studies demonstrate that stress echo is useful in the left bundle branch block. Females with dyspnea or back shoulder pain, it could be an anginal equivalent. Now I'd like to highlight a patient who had significant angina but a normal stress echo. This is a 68-year-old financial advisor who had a 2-month history of progressive chest pain consistent with angina with no risk factors, normal exam, low blood pressure, and treated with a beta blocker, nitrates, and aspirin. A stress echo showed no abnormalities except he had to stop at 3 minutes with severe chest pain. I did note that he had left ventricular hypertrophy, so I sent him from the stress lab to the lab to have cardiac markers performed, and these were distinctly abnormal with a troponin level of 98 and an NT-BNP of 9,000. The echo was read by the cardiologist reading studies that day as hypertensive heart disease, although his blood pressure was 100/70. It did report, however, severe diastolic dysfunction with an E/E prime ratio of 23 and an E/A ratio of 3, clearly very restrictive. Patient was admitted, had a coronary angiogram which was normal, a biopsy was paused for amyloid due to underlying myeloma. He was treated with a stem cell transplant and now is asymptomatic, walking 5 kilometers daily, and I saw him last week. So the time from symptoms to diagnosis was less than 3 weeks. So this is a very treatable disorder nowadays. I'd like to highlight again a normal stress echo with severe symptoms. In this case, it was dyspnea. It's a patient I saw with scleroderma. She's had it for 15 years. She underwent an echo and cardiac catheterization in 2009, which was normal. She exercises regularly at the gym, but she noted significant dyspnea within the last 4 weeks. She's a non-smoker and has no risk factors. She's on nifedipine for severe Raynaud's phenomena. You can see calcinosis with calcium deposition in her shins. In addition, she has sclerodactyly with thickened digits, acrocyanosis, and calcium deposition in her DIP joints. She underwent a number of investigations. Her blood work, ECG, chest x-ray, pulmonary function tests were normal. A CT scan and VQ scan were negative for underlying interstitial lung disease with thromboembolic disease. She saw a respiratory consultant who told her she was normal. She continued to be short of breath, got another opinion, and he said her lungs were normal. I did a stress echo, and she indeed did get severely dyspneic on walking 3 minutes on a Bruce protocol without any ST changes or arrhythmia. I could not do her oxygen saturations as her fingers were cyanosed. Her stress echo showed normal resting LV function with normal contractility at peak exercise. And looking at her right ventricle, it appeared normal, and there was no evidence to suggest pulmonary hypertension with septal flattening or a C or D-shaped ventricle at peak exercise in the short axis view. We were able to get a good tricuspid regurgitation signal with a nice Doppler envelope with a resting pulmonary systolic pressure of 30 and her peak PASP of 47. Her NT-BNP was 1137, that is elevated. Repeat cardiac catheterization showed normal coronaries, normal ejection fraction. Her left ventricular end diastolic pressure was normal, as were her PA pressures. So there's no evidence of restriction or constriction in normal coronary arteries. She was discharged, but then presented to my office severely breathless 1 week later. An ECG showed complete heart block, for which she had a dual chamber pacemaker implanted. But before we put the pacemaker in, I did an MRI because I still was not comfortable with her progressive dyspnea. The MRI demonstrated normal left and right ventricular function with LVH. But what was interesting, she had late gadolinium enhancement with diffuse increased activity in the left ventricle and septum. And this was highlighted on a nice study from Jack in heart failure, looking at the incidence of myocarditis by systematic screening with CMR. There's a 6.3-fold increased diagnosis of myocarditis when they routinely screen patients with anginal type symptoms, elevated troponin level, and underlying scleroderma. In the last 2 cases, I'd like to demonstrate what I call reassure with a stress test. And I want to highlight what one does when you have significant ST depression without chest pain. This is a 50-year-old who had ST depression with atypical chest pain with a negative MIBI in 2002 and 2004. A CT angiogram in 2008 showed mild coronary artery disease. Stress echo was negative in 2012 and 2014. Patient walked on a regular basis and had treated hypertension and dyslipidemia. His wife is a nurse, and I mentioned that because I did a stress echo in 2016 and I told her it was normal, as I told her husband. However, she was not reassured by this stress test. She wished another CT angiogram, which I felt was reasonable. So this would be 8 years after the first CTA, and this indeed did show progression in his coronary artery disease. His LAD had a proximal 80%, followed by mid 60%. The circumflex had a 50% lesion, and the RCA had some calcification. This prompted a cardiac catheterization, which showed a normal ejection fraction, a normal right coronary artery, and the LAD did have disease in the proximal and mid portion, in addition to the circumflex having significant disease with an OM branch. He was felt not to be a PCI candidate and hence was referred to cardiac surgery, who wished to operate on him for prognostic purposes. The patient adamantly refused to have coronary bypass grafting and left to be treated medically. This does highlight on angiography how one can get a reasonable correlation between CTE angiography and a cardiac catheterization. 4 years later, I'm seeing him with no complaints, but he's referred back for another stress echo. He goes 9 minutes on a Bruce, heart rate 150, endpoint fatigue. He indeed does have significant ST depression laterally, which he's had for the last 18 years.
Thank you for the invitation to participate in this virtual CME. I'll be speaking about the use of echocardiography, pitfalls and tips in detection of pulmonary hypertension. I have no disclosures. Today we're going to be speaking about understanding the context by which echocardiography is done and integration of the qualitative and quantitative aspects of the examination. We'll go over what a good TR signal is and offer some tips in terms of how to improve this important Doppler assessment. We'll contrast the use of the tricuspid regurgitation velocity with actual calculation of right ventricular systolic pressure, paying close attention to what we define as the right atrial pressure. And lastly, we'll speak about the implications on outcome and why it is important for us to be as accurate as we can be. In terms of understanding the context, it's important to know the types of patients that come to your echo lab. Your pretest likelihood of having pulmonary hypertension would depend upon the severity of illness of the patients coming in. If you are in an inpatient setting or in a pre-transplant setting, you can rest assured that the pretest likelihood of finding pulmonary hypertension is going to be higher in your lab. It is also important to integrate the quantitative information with what you see in terms of the actual images themselves. We will highlight some of those examples upcoming. In this paper by O'Leary, they looked at specifically whether the lack of a tricuspid regurgitation Doppler signal plays a role in detection of pulmonary hypertension by invasive measurement. In this population, there was a high pretest likelihood of having pulmonary hypertension. All these patients were scheduled to undergo right heart catheterization within 2 days of the echocardiographic examination. Patients had a high preponderance of congestive heart failure, ischemic heart disease, known pulmonary hypertension, or underlying pre-transplant assessment for heart, lung, or liver disease. In his cohort of over 4,600 patients, more than 1/3 of patients had no tricuspid regurgitation signal. In this population, almost half of the patients had underlying pulmonary hypertension. In contrast, in the patients with defined signal of tricuspid regurgitation, approximately 2/3 had pulmonary hypertension defined as a mean pulmonary pressure of more than 25 millimeters of mercury. Therefore, the absence of tricuspid regurgitation should not be seen as the absence of pulmonary hypertension. This is the distribution of pulmonary pressures in the groups with and without a detectable tricuspid regurgitation signal. You will notice that there is a tendency towards a higher pressure in those with detectable tricuspid regurgitation. Clinical predictors of the presence of pulmonary hypertension include the presence of left atrial enlargement, right ventricular dilatation, and dysfunction, as well as the presence of heart failure, the presence of diabetes, and high body mass index. The British Society of Echo have proposed a way of actually assessing the presence or absence of pulmonary hypertension by expanding upon the previously defined categories outlined by the European Society of Cardiography. They suggest looking at the qualitative features within the right ventricle, the pulmonary artery, or the inferior vena cava and right atrium, and determining whether there is or is not the presence of abnormalities qualitatively in 2 or more of those structures. By incorporating the actual tricuspid regurgitation velocity, together with these echo categories, we can have a better definition of whether the presence of pulmonary hypertension is seen to be of high probability, intermediate probability, or low probability. Whereas a patient who has a tricuspid regurgitation velocity of more than 3.4 meters per second surely has a higher likelihood of pulmonary hypertension. A velocity that's less than that may still be associated with pulmonary hypertension if there are more echo qualitative criteria involving the right ventricle, pulmonary, or the right atrium, as I'll show next. A right ventricular abnormality is defined as either right ventricular enlargement, that is, the basal width of the right ventricle approximating the left ventricular width, or the presence of septal flattening. Visually, basically, it is just a definition of the minor axis of the left ventricle in the plane that is parallel to the septum, being greater than that perpendicular to septum, such that the eccentricity index exceeds 1. A pulmonary artery abnormality is defined as dilation of the pulmonary artery of more than 25 millimeters, or the presence of an early pulmonic regurgitation velocity of more than 2.2 meters per second, or a shortened pulmonary acceleration time on pulse wave Doppler of less than 105 milliseconds, or the presence of notching within a pulmonary artery signal on pulse wave Doppler. And lastly, a right atrial or inferior vena cava abnormality is defined as right atrial enlargement of a right atrial area on the four-chamber view of more than 18 square centimeters, or the typical dilatation of the dilatation of the inferior vena cava more than 2.1 centimeters with impaired respiratory variation. All this still hinges upon the presence of a good tricuspid regurgitation signal, because the incorporation of the qualitative information still takes into account our ability to estimate that right ventricular signal. This group here from Stanford looked at how we can actually improve the ability to estimate right ventricular systolic pressure, and they compared it with pulmonary pressure with cardiac catheterization. They found that if you could define what a good tricuspid regurgitation signal is, you can have an area under the curve which predicts pulmonary pressure with very high precision. We know from the previous work from Chumla that there is an excellent correlation between hemodynamically derived mean pulmonary pressure and systolic pulmonary pressure, such that a systolic pulmonary pressure of 38 millimeters mercury on cardiac catheterization generally correlates with a mean pulmonary pressure of 25 millimeters mercury, which was the old standard for defining pulmonary hypertension. Therefore, being able to correlate non-invasive echo-derived pulmonary systolic pressure and correlating this with the systolic pulmonary pressure at the time of cardiac catheterization is extremely important. In this slide, the authors suggest that a good tricuspid regurgitation signal is one in which there's a complete envelope together with a clearly defined point, so we can define what the maximum velocity is. A fair signal was one in which the images were a bit fuzzier, and a poor quality signal was one in which it was very hard to discern the velocity at all. In the group that had the highest proportion of good signals, the accuracy of estimation of right ventricular systolic pressure was greatest. The authors also warn us that it's very easy to overestimate the Doppler assessment of right ventricular systolic pressure if we turn the gain up too high. We have to pay close attention to minimize the gain so that we can get the velocity, or the so-called motor velocity, of the majority of the blood cells. Shown on panel B is an estimate of the actual velocity with proper gain, and at the same time overgaining and leading to overestimation of the right ventricular systolic pressure. Shown in this panel, the authors also highlight various other pitfalls, that is, use of a Doppler signal that is not parallel to the flow of blood, leading to underestimation of the tricuspid regurgitation velocity. Overgain is also demonstrated. And lastly, one can get a much better appreciation of the maximum velocity if we turn the sweep speed a bit faster to allow us to see the fuzz and discern the fuzz or the overestimation from the true motor velocity. This is demonstrated in the bottom right-hand corner. This is one of our examples of a patient who clearly has septal flattening and is suspected to have pulmonary hypertension. In this signal, on the left-hand side, you can see that there is an angulation problem such that the path of blood flow is different than that of the Doppler signal, leading to underestimation of the right ventricular systolic pressure. On the bottom right-hand corner, you will notice that the maximum velocity can be estimated, but the example here is that of over-exaggeration due to lack of consideration of the motor velocity. You notice that in this particular example, when actually compared to right heart catheterization, that the velocities reported in this study were in fact overestimated due to those pitfalls identified. In fact, the presence of a good tricuspid regurgitation signal depends upon the underlying disease. In people with primary pulmonary arterial hypertension, there is a high likelihood of a good quality or fair quality signal, whereas in those patients with anatomic lung disease, such as COPD or pulmonary fibrosis, more than likely the presence of tricuspid regurgitation produces a poor signal. When the authors compared a level 3 reader with that of the right ventricular systolic pressure derived on cardiac catheterization, they found that there was relatively good agreement and that the levels of disagreement were usually related to a not well-defined tricuspid regurgitation signal. Less well correlation was seen between right heart catheterization and that reported in the clinical report, with errors found not only in the incomplete signal of tricuspid regurgitation, but also overestimation due to lack of consideration of the modal frequency, as well as sometimes an underestimation of the right atrial pressure. This slide highlights the correlation between echo and cath-derived right ventricular systolic pressure, depending upon whether the reader was a level 3 reader, a level 2 reader, or whether it was just reflected in the clinical report. Notice that the line of agreement is much better with increasing levels of experience, as reflected in the tighter fit on the regression line on the left, as well as the tighter fit in the Bland-Altman plot on the right. In terms of suggested tips, not only should we choose the best window for alignment of the tricuspid regurgitation signal, but we should also adjust the sweep speed to a higher sweep speed, avoiding premature ventricular contractions, reducing the Doppler gain and avoiding extrapolation of the signal, and pay close attention to the modal velocity. Saline contrast may be helpful to define and discern signals that are not complete. And lastly, and we'll talk about this later, we need to use multiple methods of assessment of the right atrial pressure. This is a publication from a journal looking at transthoracic echo in children. You notice that in the publication there is overgain leading to overestimation of right ventricular systolic pressure. So this occurs not only in your labs, but also in published literature. On the two panels on the right, a poor tricuspid regurgitation signal can be enhanced by the use of saline contrast. But remember, saline contrast can also lead to a shaggy signal and leading to overestimation of the actual pressure. Well, what about if we were to use different levels of tricuspid regurgitation? Does the presence of severe tricuspid regurgitation affect our ability to estimate the right ventricular pressure? In this paper, they looked at patients who had varying degrees of tricuspid regurgitation, and they found that the presence of severe tricuspid regurgitation was a major determinant in being able to overestimate right ventricular systolic pressure. Whereas there was relatively good agreement with no systematic bias between echo and cath-derived pulmonary pressure in those with mild to moderate tricuspid regurgitation. In those with severe regurgitation, there was a tendency towards overestimation of right ventricular systolic pressure by echo Doppler. And in fact, severe tricuspid regurgitation was the only variable detected on multivariate analysis as a parameter leading to overestimation. And we know from other studies, most of that is because of inaccuracy in the estimation of the right atrial pressure in the presence of severe tricuspid regurgitation. And this has been termed the Achilles heel of echocardiography when there is significant tricuspid regurgitation. This has further led investigators to consider, should we use the actual absolute velocity of tricuspid regurgitation rather than calculating right ventricular systolic pressure? Surely then we can obviate the situation by not having to estimate the right atrial pressure directly. And these authors actually did just that. They looked at 136 patients and whom they had either right heart cath as well as echocardiography. They wanted to know which was a better predictor. Well, it's pretty well a wash. If you look at the receiver operator curve, the right ventricular systolic pressure did about as well as the actual tricuspid regurgitation velocity. And whereas the right ventricular systolic pressure had a higher sensitivity, it had a lower specificity in detection of pulmonary hypertension compared to just assessment of the tricuspid regurgitation velocity by itself. And a lot of this has to do with non-invasive evaluation of right atrial pressure, which can be problematic. We all know that from the various guidelines that we should look at more than just the inferior vena cava. In fact, dilated inferior vena cava would diminish respiratory collapse. It's just one parameter to indicate an elevation in right atrial pressure. Other parameters, which I will go over subsequently, are also important. In addition, inferior vena cava dilation can occur in the presence of normal right atrial pressure under various conditions. The degree of respiratory variation can also help, but depending upon the study that we use, we might find different strata for determining the actual right atrial pressure, depending upon the degree of respiratory variation. Shown here are two patients, one on the left and one on the right. You notice that the right atrial pressure may be high in both situations. The inferior vena cava certainly is dilated. However, the patient on the right has a dilated right atrium, and though not shown on this non-moving picture, there is also bowing of the interatrial septum from right to left. And this distinguishes the presence of high right atrial pressure in this individual as contrasted to the other individual who had a dilated inferior vena cava in the presence of normal right atrial pressure. Further information can be derived from the systemic vein Doppler signal. On the left-hand side, you notice a superior vena cava pulse wave Doppler signal of a normal individual demonstrating systolic preponderance of flow. In the hepatic vein signal seen on the right, the systolic wave is smaller than the diastolic wave and is reflective of elevation in right atrial pressure. Another method of assessing right atrial pressure or enlargement in right atrial pressure can be determined using pulse wave Doppler of the tricuspid inflow and comparing this with the tissue Doppler velocity. Panel A on the left demonstrates an E-wave velocity of 84 centimeters per second across the tricuspid valve, and when divided by the E' velocity at the tricuspid valve annulus, this is under 6. This signifies a normal right atrial pressure. The patient on panel B has a smaller absolute E-wave velocity, but when compared with a very low E' velocity, that ratio is greater than 6, reflective of an elevation of right atrial pressure. In fact, we should be using more than just the inferior vena cava, and this paper highlights that the importance of not just looking at one characteristic, but looking at multiple characteristics to determine whether in fact the right atrial pressure is elevated or not. Well, why is this all important? We know that the more accurate we can be, the more precise we can be, and it has implications in terms of the outcome of the patients. In fact, Strange found that the threshold for detecting pulmonary hypertension may be actually a lot smaller than we think. And they associated the presence of pulmonary pressure with mortality in 313,000 patients in this Australian cohort. The distribution of right ventricular systolic pressure is outlined here. And you notice that most patients didn't have very high pressure. However, regardless of whether you look at quintiles of pulmonary pressure on the right or absolute numbers on the left, a higher pulmonary artery pressure was associated with increased mortality and increased cardiovascular mortality, as exemplified by a reduction in the cumulative survival curve. And even mild degrees of pulmonary hypertension, around 40 to 49, may be associated with abnormal outcomes and increased mortality. This is not the only paper. Other studies, as demonstrated in a systematic review and meta-analysis, have shown that even mild degrees of pulmonary hypertension can be associated with increased mortality. And that's independent of whether the assessment of pulmonary pressure is determined quantitatively using right heart catheterization or qualitatively using echocardiography. Notice, however, because of the inherent variability in the signals of right ventricular systolic pressure by Doppler, the fit is much better with right heart cath. What's important about this is because increased mortality is associated with even milder degrees of pulmonary hypertension, this has contributed to the redefinition of pulmonary hypertension being defined as of 2019 as a mean pulmonary pressure of more than 20 rather than 25 millimeters of mercury. In summary then, I've taken you through the integration and need to analyze not just the quantitative signals, but also the qualitative information within the echocardiogram. It's important to obtain as good a tricuspid regurgitation signal as possible and to be as precise as possible in estimation of the right atrial pressure in order to derive the estimated right ventricular systolic pressure. mainly because the detection of even mild pulmonary hypertension has huge implications on the actual outcome. Taking this back to your lab, it's important to have quality assurance with both your technologists and your physicians, and make sure that your reports go out with qualitative and quantitative information such that the isolated value of right ventricular systolic pressure is not the only thing that's reported. And lastly, be aware of even modest elevation in right ventricular systolic pressure. I thank you for your time, and I look forward to your questions and comments. Thank you.
Thank you, and good afternoon. I'm Sharon Mulvey from Halifax, Nova Scotia, and this afternoon we're going to be talking about echo contrast in the critical care setting. I do have several conflict of interest to disclose. I do have a grant recently awarded from the Canadian Cardiovascular Society. I'm an advisory board member for Lantheus Medical Imaging and a steering committee member for Novo Nordisk SOUL trial. And I will be discussing off-label uses of ultrasound enhancing agents for myocardial perfusion as recommended by ASC guidelines. The learning objectives that I'd like to cover with you over the next very quick 20 minutes is to understand what ultrasound enhancing or contrast agents are and how to administer them, to know indications for the use of ultrasound enhancing agents in the critical care and emergency department environments, to describe the clinical impact of their use, and to recognize the incremental value of myocardial contrast echo perfusion imaging, and to become aware of new and future relevant applications of echo contrast. What are contrast echo agents? Or, as we're calling them as well, ultrasound enhancing agents. And I'd just like to make a point about why we are using the terminology ultrasound enhancing agents. It's to reduce the confusion really in communications with our patients. When patients hear the word contrast, they often think of radiographic dye that could impact on their kidneys. And so it's important for them to understand that ultrasound contrast agents are different, and the terminology, therefore, ultrasound enhancing agents is what we've chosen to use. Ultrasound enhancing agents are stabilized gas microspheres or microbubbles, which are sized to pass through the smallest capillaries. Microbubbles are composed primarily of air, stabilized by a small amount of inert gas, and enclosed by shell. The components of ultrasound contrast agents and desirable characteristics are listed here, and the different companies have different components in their agents. The unique thing about microbubbles in comparison to most other imaging contrast agents is that they are pure intravascular tracers and they do not extravasate outside the microcirculation. Indeed, validation studies using radio-labeled microspheres show excellent correlation with microbubbles for the quantitative assessment of myocardial blood flow, as shown here. There are currently 3 approved ultrasound enhancing agents by Health Canada, as well as the FDA, but here in Canada, only 2 are marketed commercially at the present time, including Definity and Soniview, which is also known as Lumazon in the US and in Europe. It is known also as Soniview. The approved indications are for left ventricular opacification and endocardial border delineation. However, they are very useful for the assessment of myocardial perfusion as well, and we will discuss that, but it is recognized to be off-label. What are the guidelines for usage of echo contrast, and particularly as it relates to the critical care setting? Specific reference to the use of contrast echo in emergency and critical care settings was first published in 2013 in the recommendations from the European Association of Cardiovascular Imaging. And they specifically recommended contrast echo for the evaluation of global and regional systolic function and post-infarction complications, including left ventricular pseudoaneurysm and thrombus. And as well, contrast echo has a role to play in the assessment of aortic dissection. They noted that there were no reports of mortality increase in critically ill patients upon contrast administration. The ASE Guidelines Update document published in 2018 also provided specific guidance for the use of ultrasound-enhancing agents in critical care and emergency settings. And these recommendations are summarized here, specifically addressing the situation of non-diagnostic electrocardiograms and the incremental value for both left ventricular pacification for assessment of wall motion abnormalities and for perfusion, as well as evaluation of the known complications of myocardial infarctions, such as left ventricular function depression with regionality, thrombi, microvascular flow abnormalities, reperfusion assessments, and complications post-MI. And of course, in the current COVID era, our ED and critical care colleagues are experiencing unique and overwhelming competing needs for accurate, rapid information with minimal contact and sparing of personal protective equipment. Both the ASE and CSE have produced guidance statements on performance of echo in the COVID environment, and ultrasound-enhancing agents are mentioned as having particular potential benefit to improve accuracy and speed of imaging, as noted here. So with that brief introduction, let's address what are the applications for use in the ED and critical care environments. The obvious one is to improve the feasibility of transthoracic echo in a generally hostile environment of technically challenging echoes due to the patient positioning and comorbidities that we have discussed. There's clear benefit in changing a non-diagnostic study to a diagnostic one, avoiding downstream testing, additional unnecessary downstream testing, transportation, and exposures. What appeared to be possibly very poor LV function in this case is actually hyperdynamic, as you can see when contrast is added. What you don't see certainly can hurt you. From beyond the initial recommendation of greater than or equal to 2 contiguous LV segments not adequately seen, the most recent guidelines state that if the indication is to improve the cardiac structure or function assessment, then contrast can be used without counting up the number of segments. Beyond general left ventricular function assessment, regional wall motion abnormality assessment is critical in evaluation of a patient with symptoms suggestive of an ischemic syndrome. The differential of global from regional wall motion abnormalities is critical, as is the knowledge of the association of the typical myocardial perfusion distribution of epicardial coronary arteries. Here is an example of what appears to be normal regional wall motion on an unenhanced echo on the left, but due to foreshortening, this apical long axis view is not optimal, and with enhancement, now a true apical long axis view can be obtained, and we can see clearly that there is an inferolateral regional wall motion abnormality as demonstrated in the very low mechanical index image on the right-hand side. There's also relative thinning of the myocardium in that area. Here is an example of the opposite situation where there appears to be a regional wall motion abnormality at the apex. And note that in the upper right-hand corner that the patient's electrocardiogram showed deep T-wave inversions. However, when contrast is administered, we can see that indeed there is no regional wall motion abnormality at the apex, but rather there is left ventricular apical hypertrophy, which is often a masquerader for a wall motion abnormality. I've seen this happen several times, and many colleagues similarly. So if the story isn't fitting and you suspect that there is apical hypertrophy, it is essential to use contrast to make this diagnosis. Complications of acute cardiac ischemia are often seen in the critical care setting. Here is a patient with an obvious apical wall motion abnormality and findings certainly consistent with an apical thrombus. However, with contrast enhancement, the extent of the thrombus and actually the mobility along the edge of it can be readily seen, and the infarcted area is more clearly identified. Demonstrated here is the value of ultrasound enhancing agents to confirm a pseudoaneurysm. Here on the left, you can see that there is an echolucent structure adjacent to the left ventricular apex. On the right, with the administration of contrast, this clearly defines a left ventricular apical pseudoaneurysm with a narrow neck and a wide body of the aneurysm, classic for this diagnosis. Beyond the use of ultrasound enhancing agents for LV opacification, myocardial perfusion can be quite helpful, particularly in managing acute ischemic syndrome patients. This demonstrates the use of LV opacification to show a wall motion abnormality in the anteroseptal to apical region seen here in this apical long axis view, along with an perfusion demonstration which is slightly delayed but present despite the area of reduced function evidenced by the wall motion abnormality. So this would be consistent with a wall motion or function perfusion mismatch. And in this case, this was a lady who'd had a respiratory arrest due to an anaphylactic reaction, and she suffered a non-STEMI with elevation of troponins, and she also had acute kidney injury with an elevation of her creatinine. So the question was she most likely had a type 2 MI and likely related to stress cardiomyopathy. There was reluctance to take her to the cath lab because of her elevation in creatinine. So we didn't. And a month later, she came back and she had normal LV function. It had completely recovered, consistent with the retrospective diagnosis of Takotsubo's. And thus, the important thing is that the perfusion information, which was slightly delayed but preserved despite the area of regional wall motion abnormality, was very helpful in her management. Now, I'd like you to contrast this, the last case, to this case. This is a 61-year-old female who had was a couple of days post-op renal transplant, and on a routine electrocardiogram before dismissal was read as having STEMI. She had significant ST segment elevations in the anterior precordial leads. And in her perfusion echocardiogram, as you can see here on the left, after the high mechanical index flash there it was, you see very, very black area where the wall motion extends from the proximal anteroseptum. Again, this is a apical long axis view, and extending all the way around the apex and into the inferolateral wall. Now, the point is that there's no evidence of microbubbles in this akinetic segment. So one would think that this is most consistent with infarction in this area. And indeed, she did go to the cath lab. She was found to have a subtotal proximal LAD stenosis, and this was stented. And when she returned a month later for a follow-up echo, she unfortunately has a persistent wall motion abnormality that you can see here from the mid to apical region. So you could predict in this case, because of the absence of perfusion and the distribution of the wall motion abnormality, that this function was not going to recover, and indeed it didn't. Because ultrasound enhancing agents can be very helpful in differentiating intracardiac masses at the bedside in a critical care or ED environment. As shown on the left, a thrombus has no perfusion and remains black or echolucent, while a tumor is perfused and will demonstrate microbubbles within. In general, a malignant tumor is more highly perfused, as seen here on the far right in the right ventricle, filling nearly the entire right ventricular apex. There is a mass which is very highly perfused. In the center is another mass, and this has a less degree of perfusion than seen in the metastatic tumor, and slightly less than what is seen in the myocardium. This appearance is consistent with a myxoma. Aortic dissection is another condition seen not infrequently in the ED, for which the diagnosis is critically important and sometimes easy to miss. Contrast echo can readily demonstrate true and false lumina, and sometimes the entry tear, as seen here in the right panel. In a single-center study of over 100 patients, the sensitivity and specificity of enhanced transthoracic echo were similar to conventional transesophageal echo in detecting dissection of the ascending aorta on the order of 93 versus 96% and 98 versus 96% respectively, as well as in the arch. What about using contrast echo in the assessment of patients with assist devices or circulatory support? We looked at our Mayo experience several years ago when Dr. Noel Fine was an echo heart failure advanced fellow with us and found that the use of contrast appeared safe and useful. Here you can see several case examples with non-contrast images on the left panel and after contrast on the right in the still frames. On the right-hand side, you can see a video which demonstrates the presence of a thrombus adjacent to the inflow cannula at the left ventricular apex. Overall, ventricular function assessments were improved with the improved image quality with contrast, and significant management impacts were observed. We also looked at our Mayo experience several years ago regarding ECMO, and although contrast was used infrequently, it was helpful and safe, with the proviso that a perfusionist must be available at the time of the study in the event that the air detector alarms, which can occur due to the presence of the microbubbles. The videos show an example study of a contrast benefit in a young woman on VA ECMO for complications of sepsis. A mass was seen on the non-contrast echo and was clarified to be extracardiac, consistent with a mediastinal coagulum causing external cardiac compression. So how do you optimally perform contrast echo? Ultrasound machine settings to optimize contrast are essential to understand. Most often we prefer very low mechanical index imaging for left ventricular opacification because this preserves the contrast agent, destroying the least amount and giving the best images. It's important to understand that if the endocardial border is not distinctly seen as very low mechanical index imaging progresses, the use of transient high mechanical impulses will restore the sharp demarcation of the endocardial border, while also giving you perfusion information. Shown here are the comparisons between tissue harmonic unenhanced imaging on the left, which is always at high MI. In the center is low mechanical imaging with contrast, with a marginally beneficial contrast effect. And at the far right is the optimal strategy of very low mechanical index imaging. And for those who are astute, there is indeed a small but mobile thrombus at the apex of the left ventricle, which is only seen with the very low mechanical index imaging. To understand how best to optimize our ultrasound machine settings, it helps that we understand how microbubbles interact with ultrasound. They expand and contract as they are resonating in an ultrasonic field, and this is termed nonlinear resonance. This microbubble was imaged with a special camera at 25 million frames per second, and you can see the expansion and collapsing of the microbubble. Shown in this schematic is the effect of a microbubble that is exposed to increasing acoustic power or mechanical index, the MI. At low MI, at the left of the diagram, only linear backscatter is reflected from the microbubble. But as the MI is increased, the microbubble begins to resonate, creating nonlinear resonance or harmonics. And with a greater increase in the mechanical index, acoustic cavitation or microbubble disruption occurs, destroying the microbubbles. A large signal is released at the time of this cavitation. The nonlinear resonance permits enhanced ability to detect microbubbles compared to the surrounding tissue, and thus is the preferred strategy for both left ventricular opacification and perfusion imaging. There is ample literature supporting perfusion using ultrasound enhancing agents, and although no commercially available ultrasound enhancing agent as yet has a specific indication for perfusion, it has been recommended in the AAC guidelines because of this substantial literature supporting. Indeed, the emergency room is a specific location that has been studied with respect to the incremental value of perfusion in patients presenting with chest pain, and a non-diagnostic ECG in particular. Assessment of regional wall motion abnormalities in combination with perfusion was found to be the most robust in predicting outcomes, with patients that had a normal wall motion and normal perfusion having the best outcomes. What is the clinical impact of contrast echo use, particularly in critical care areas? In an interesting study from Baylor that's evaluated not only the impact of ultrasound enhancing agents on image quality, which you can see here certainly was improved with the addition of contrast, but they also evaluated the impact on management outcomes. And they found that the most significant effect was in the ICU settings, with over half of patients in the surgical intensive care units and a third of patients in the medical intensive care units having changes in management associated with the test information that was received that included the ultrasound enhancing agent results versus those that didn't. Moreover, there was actually a cost savings by avoiding unnecessary downstream subsequent costs in these patients that could have a definitive diagnosis based upon the results of the contrast echo. What about safety? The safety profile of contrast agents has been extensively studied, although a black box due to a retrospectively unsubstantiated safety signal associated with some post-marketing pseudo complications was placed in 2007 and it still remains. The only current contraindications to ultrasound enhancing administration includes a known allergy or sensitivity to the product. Indeed, a citizen's petition has been submitted to the FDA almost 2 years ago now to rescind the black box, and response is yet pending. Warnings remain regarding use in critically ill as a caution. It is important to note, however, that rare, that means on the order of less than 1 in 10,000, hypersensitivity reactions can occur, and they're thought to be related to a complement activation related pseudoanaphylaxis or a type 1 type hypersensitivity. For this reason, ultrasound enhancing agents should only be utilized in settings where resuscitative equipment is readily available. I'd like to close with just a few words about some exciting work that is being done by colleagues in the area of sonothrombolysis, because this is very relevant to the emergency department and critical care. This groundbreaking work is being done by Dr. Wilson Matthias and his group in Brazil in collaboration with Tom Porter in Omaha, Nebraska. And they've been using intermittent high MI ultrasound treatments, which are delivered with commercially available ultrasound transducers and commercially available contrast agents. They're given before PCI and for 30 minutes after PCI. And they have been able to improve angiographic recanalization and microvascular perfusion in these patients with acute STEMIs. And as well, they've been able to visualize the infarct risk and reperfusion areas, which have improved. So there is a utilization of contrast echo as both a diagnostic and a therapeutic tool with this technique. But moreover, just this last month in Circulation Imaging, they published additional 6-month outcomes data, which showed that the observed improvements in the microvascular flow resulted in better myocardial mechanics and reduced left ventricular remodeling, as evidenced by improvements in both LVEF and global longitudinal strain. So protocols are also ongoing in Europe, which are exploring the administration of this sonothrombolysis technique even before patients get to the emergency room, in other words, in the ambulance. So this is something to watch out for, and certainly is proving to be looking like a promising technique. So the take-home messages include the following. regarding ultrasound enhancing contrast agents for critical care and the emergency department. They are useful, safe, and cost effective. They provide improved feasibility, diagnostic accuracy, and prognostic value. They use very low MI with a brief high mechanical index flash. This type of imaging is best to be able to evaluate both left ventricular opacification and perfusion. The future is very exciting with the therapeutic use of contrast ultrasound in the emergency room or even before patients arrive in the emergency room, and this is termed sonothrombolysis. It's important also, of course, in the critical care and ED settings to recognize that contrast-enhanced ultrasound also has non-cardiac applications of relevance to the intensivist and the emergency doctor. So I thank you for your attention, and I look forward to your questions. Thank you.